Hello everyone, and welcome back to another stream of advanced pharmacology. Today we're talking about the antidysrhythmic drugs in chapter 41. Antidysrhythmic drugs. A dysrhythmia is defined as an abnormality in the rhythm of the heartbeat. In their mildest forms, dysrhythmias have only modest effects on cardiac output. However, in their most severe forms, dysrhythmias can disable the heart so that no blood is pumped at all. Because of their ability to compromise cardiac function, dysrhythmias are associated with a high degree of morbidity and mortality. There are two basic types of dysrhythmias: tachydysrhythmias and bradydysrhythmias. In this chapter, we are only considering the tachydysrhythmias. This is by far the largest group of dysrhythmias, and in the group that responds best to drugs. We do not discuss the bradydysrhythmias because they are few in number and are commonly treated with electronic pacing. When drugs are indicated, atropine is usually the agent of choice. It is important to appreciate that virtually all of the drugs used to treat dysrhythmias can also cause dysrhythmias. These drugs can create new dysrhythmias and worsen existing ones. Because of these pro-dysrhythmic actions, antidysrhythmic drugs should be employed only when the benefits of treatment clearly outweigh the risk. For two reasons, the use of antidysrhythmic drugs is declining. First, research has shown that some of these agents actually increase the risk for death. Second, non-pharmacologic therapies, especially implantable defibrillators and radiofrequency ablation, have begun to replace drugs as the preferred treatment for many dysrhythmia types. And note on terminology, dysrhythmias are also known as arrhythmias. Because the term arrhythmia denotes an absence of cardiac rhythm, whereas dysrhythmia denotes an abnormal rhythm, dysrhythmia would seem the more appropriate term. So, the introduction to cardiac electrophysiology, dysrhythmias, and the antidysrhythmic drugs. In this section, we discussed the background information that will help you understand the action and use of antidysrhythmic drugs. We begin by reviewing the electrical properties of the heart and the electrocardiogram. Next, we discuss how dysrhythmias are generated. After that, we discuss classification of the antidysrhythmic drugs as well as the ability of these drugs to cause dysrhythmias. We can conclude by the discussion the major dysrhythmias and the basic principles that guide antidysrhythmic therapy. Electrical properties of the heart. Dysrhythmias result from the alteration of the electrical impulses that regulate the cardiac rhythm, and antidysrhythmic drugs control rhythm by correcting or compensating for these alterations. Accordingly, to understand both the generation and treatment of dysrhythmias, we must first understand the electrical properties of the heart. Therefore, we begin by reviewing the pathways and timing of impulse conduction, cardiac action potentials, and basic elements of the EKG. Impulse conduction, pathways, and timing. For the heart to pump effectively, contraction of the atria and ventricles must be coordinated. Coordination is achieved through precise timing and routine of impulse conduction. In the healthy heart, impulses originate in the sinoatrial SA node, spread rapidly through the atria, pass slowly through the atrioventricular node, and then spread rapidly through the ventricles by the way of the His-Purkinje system. So here you're taking a look at figure 41.1, the cardiac conduction pathway. The SA node. Under normal circumstances, the SA node serves as a pacemaker for the heart. Pacemaker activity results from the spontaneous phase 4 depolarization. Because cells of the sinus node usually discharge faster than other cells that display automaticity, the SA node normally dominates all other potential pacemakers. After the SA node discharges, impulses spread rapidly through the atria along the internodal pathway. This rapid conduction allows the atria to contract in unison. The AV node. Impulses originating in the atria must travel through the AV node to reach the ventricles. In the healthy heart, impulses arriving at the AV node are delayed before going on to excite the ventricles. This delay provides time for blood to fill at the ventricles before ventricular contraction. His-Purkinje system. The fibers of the His-Purkinje system consist of specialized conducting tissue. The function of these fibers is to conduct electrical excitation very rapidly to all parts of the ventricle. Stimulation of the His-Purkinje system is caused by the impulses that leave the AV node. These impulses are conducted rapidly down the bundle of His, enter the right and left bundle branches, and then distribute to the many fine branches of the Purkinje fibers. Because impulses travel quickly through the system, all regions of the ventricles are stimulated almost simultaneously, producing synchronized ventricular contraction, with resultant forceful ejection of blood. Cardiac action potentials. Cardiac cells can initiate and conduct action potentials, consisting of self-propagating waves of depolarization, followed by repolarization. As in neurons, cardiac action potentials are generated by the movement of ions into and out of the cells. These ion fluxes take place by the way of the specific channels in the cell membrane. In the resting cardiac cell, negatively charged ions cover the inner surface of the cell membrane, whereas positively charged ions cover the external surface. Because of the separation of charge, the cell membrane is said to be polarized. Under proper conditions, channels in the cell membrane open, allowing positively charged ions to rush in. This influx eliminates the charge difference across the cell membrane, and thus the cell is said to be depolarized. After depolarization, positively charged ions are extruded from the cell, causing the cell to return to its original polarized state. In the heart, two kinds of action potentials occur: fast potentials and slow potentials. These potentials differ with respect to the mechanisms by which they are generated, the kinds of cells in which they occur, and the drugs to which they respond. Profiles of fast and slow potentials are depicted in Figure 41.2. Please note that the action potentials in this figure represent the electrical activity of single cardiac cells. Such single cells recordings, which are made using experimental preparations, should not be confused with the EKG, which is made using surface electrodes, and thus reflects the electrical activity of the entire heart. So here you're taking a look at a picture of the ion fluxes during cardiac action potential. An excellent spot to hit pause if you're unfamiliar. Fast potentials. Fast potentials occur in fibers of his Purkinje system and in atrial and ventricular muscle. These responses serve to conduct electrical impulses rapidly throughout the heart. As was shown in Figure 41.2a, fast potentials have 5 distinct phases, labeled 0 through 4. As we discuss each phase, we focus on its ionic basis and its relationship to the action of antidysrhythmic drugs. So we'll start off with phase 0. In phase 0, the cell undergoes the rapid depolarization in response to influx of sodium ions. Phase 0 is important in that the speed of phase 0 depolarization determines the velocity of impulse conduction. Drugs that decrease the rate of phase 0 depolarization slow impulse conduction through the His-Purkinje system and myocardium. In phase 1, during phase 1, rapid but partial repolarization takes place. Phase 1 has no relevance to any antidysrhythmic drug. Phase 2 consists of a prolonged plateau in which the membrane potential remains relatively stable. During this phase, calcium enters the cell and promotes contraction of atrial and ventricular muscles. Drugs that reduce calcium entry during phase 2 do not influence cardiac rhythm. However, because calcium influx is required for contraction, these drugs can reduce myocardial contractility. Phase 3. Phase 3, rapid repolarization takes place. This repolarization is caused by extrusion of potassium from the cell. Phase 3 is relevant in that delay of repolarization prolongs the action potential thereby prolongs the effective refractory period. Phase 3 repolarization can be delayed by drugs that block potassium channels. Phase 4, the final phase. During phase 4, two types of electrical activity are possible. The first, the membrane potential may remain stable. And in part 2, the membrane may undergo spontaneous depolarization. In cells undergoing spontaneous depolarization, the membrane potential gradually rises until a threshold potential has been reached. At this point, rapid phase 0 depolarization takes place, setting off a new action potential. Therefore, it is phase 4 depolarization that gives cardiac cells automaticity. The capacity for self-excitation makes potential pacemakers of all cells that have it. Under normal conditions, his Purkinje cells undergo very slow spontaneous depolarization, and myocardial cells do not undergo any. However, under pathologic conditions, significant phase 4 depolarization may occur in all of these cells, and especially in Purkinje fibers. When this happens, a dysrhythmia can result. So, are slow potentials. Slow potentials occur in cells of the SA node and AV node. The profile of a slow potential is depicted in figure 41.2b. Like fast potentials, slow potentials are generated by ion fluxes. However, the specific ions involved are not the same for every phase. From a physiologic and pharmacologic perspective, slow potentials have three features or special significance. Phase 0 depolarization is slow and mediated by the calcium influx. These potentials conduct slowly, and spontaneous phase 4 depolarization in the SA node normally determines the heart rate. So, in phase 0, the depolarization phase of slow potentials differs significantly from phase 0 of fast potentials. Again, as we can see from figure 41.2, whereas phase 0 of fast potentials is caused by a rapid influx of sodium, phase 0 of slow potentials is caused by the slow influx of calcium. Because calcium influx is slow, the rate of depolarization is slow. And because depolarization is slow, these potentials conduct slowly. This explains why impulse conduction through the AV node is delayed. Phase 0 of the slow potential is a therapeutic significance in that drugs that suppress calcium influx during phase 0 can slow or stop AV conduction. Phase 2 and 3. Slow potentials. Lack of phase 1. Phases 2 and 3 of the slow potential are not significant with respect to the actions of antidysrhythmic drugs. Phase 4. Cells of the SA node and AV node undergo spontaneous phase 4 depolarization. The ionic basis of this phenomenon is complex and incompletely understood. Under normal conditions, the rate of phase 4 depolarization in cells of the SA node is faster than in all the other cells of the heart. As a result, SA node discharges first and determines the heart rate. Therefore, the SA node is referred to as the cardiac pacemaker. Again, as shown in figure 41.2b, two classes of drugs, your beta blockers and calcium channel blockers, can suppress phase 4 depolarization. By doing so, these agents can decrease automaticity in the SA node. So, the electrocardiogram. The EKG provides a graphic representation of cardiac electrical activity. The EKG can be used to identify a dysrhythmia, and monitor responses to therapy. The major components of an EKG are shown here in Figure 41.3. As we can see, three features are especially prominent: a P wave, the QRS complex, and the T wave. The P wave is caused by the depolarization in the atria. Therefore, the P wave corresponds to atrial contraction. The QRS complex is caused by the depolarization of the ventricles, so the QRS complex corresponds to ventricular contraction. If the conduction through the ventricles is slowed, the QRS complex will widen. The T wave is caused by the repolarization of the ventricles, so this wave is not associated with overt physical activity of the heart. In addition to the features you just described, the EKG has three other components of interest: the PR interval, the QT interval, and the ST segment. The PR interval is defined as the time between the onset of the P wave and the onset of the QRS complex. Lengthening of the interval indicates a delay in conduction through the AV node. Several drugs may increase the PR interval. The QT interval is defined as the time between the onset of the QRS complex and the completion of the T wave. This interval is prolonged by drugs that delay ventricular repolarization. The ST segment of this portion of the EKG that lies between the end of the QRS complex and the beginning of the T wave. Digoxin may depress the ST segment. So, the generation of dysrhythmias. Dysrhythmias arise from two fundamental causes: a disturbance of impulses, or the impulse formation, and the disturbance of impulse conduction. One or both of these disturbances underlie all dysrhythmias. Factors that may alter automaticity or conduction include hypoxia, an electrolyte imbalance, cardiac surgery, reduced coronary blood flow, myocardial infarctions, and finally, antidysrhythmic drugs. So, disturbances of automaticity. Disturbances of automaticity can occur in any part of the heart. Cells normally capable of automaticity can produce dysrhythmias if their normal rate of discharge has changed. In addition, dysrhythmias can be produced if the tissues that do not normally express automaticity develop a spontaneous phase 4 depolarization. Altered automaticity in the SA node can produce tachycardia or bradycardia. Excessive discharge of sympathetic neurons that innervate the SA node can augment automaticity in such a degree that sinus tachycardia may result. Excessive vagal discharge can suppress automaticity to such a degree that sinus bradycardia may result. Increased automaticity of the Purkinje virus is a common cause of dysrhythmias. The increase can be brought on by injury or by excessive stimulation of the Purkinje virus by the sympathetic nervous system. If Purkinje virus begin to discharge faster than the SA node, they will escape control by the SA node, potentially causing a serious dysrhythmia that may result. Under special conditions, automaticity may develop in cells of the atrial and ventricular muscle. If these cells fire faster than the SA node, dysrhythmias will result. So here is an excellent spot to hit pause so you can see the patient-centered care across the lifespan on antidysrhythmic drugs. Disturbances of conduction. So we'll start off with an AV block. Impaired conduction through the AV node produces a varying degree of AV block. If impulse conduction is delayed, the block is termed a first degree. If some impulses pass through the node but others do not, the block is termed second degree. And if all traffic through the AV node stops, the block is termed third degree. Re-entry. Re-entry, also referred to as recirculating activation, is a generalized mechanism by which a dysrhythmia can be produced. Re-entry causes dysrhythmias by establishing a localized self-sustaining circuit capable of repetitive cardiac stimulation. Re-entry results from a unique form of a conduction disturbance. The mechanism of reentry activation and the effects of drugs on this process are described next. In normal impulse conduction, electrical impulses travel down both branches of the Purkinje fibers to cause excitation of the muscle at two locations. Impulses created within the muscles travel in both directions, away from their site of origin. Those impulses that are moving toward each other meet midway between the two branches of the Purkinje fibers. Because in the wake of both impulses, the muscle is in a refractory state. Neither impulse can proceed further, so both impulses stop. And here is an excellent spot to hit pause so you can see how that would look in terms of a picture. In the reentrant circuit in figure 41.b, there is a region of one-way conduction block of one branch of the Purkinje fiber. This region prevents conduction of impulses downward, but does not prevent impulses from traveling upward. A region of one-way block is essential for reentrant activation. So, how does one-way block lead to a reentrant activation? As an impulse travels down the Purkinje fiber, it is blocked in one branch but continues unimpeded in the other branch. Upon reaching the tip of the second unblocked branch, the impulse stimulates the muscle. As described earlier, the impulse in the muscle travels to the right and to the left away from its site of origin. However, in this new situation, as the impulse travels towards the impaired branch of the Purkinje fiber, it meets no impulse coming from the other direction, and continues on, resulting in a stimulation of the terminal end of the first branch. The stimulation causes an impulse to travel backward up the blocked branch, or one way. The impulse can pass upward through the region of the block and then back down into the unblocked branch, causing a re-entrant activation of the branch. Under proper conditions, the impulse will continue to cycle indefinitely, resulting in the repetitive ectopic beats. There are two mechanisms by which drugs can abolish a reentrant dysrhythmia. First, they can improve conduction in the sick branch of the Purkinje fiber, and can thereby eliminate the one-way block. Alternatively, drugs can suppress conduction in the sick branch, thereby converting a one-way block into a two-way block. So those would be figures 41.4c and d, respectively. Classification of antidysrhythmic drugs. According to the Vaughan-Williams classification scheme, the antidysrhythmic drugs fall into 5 categories. There are 4 major classes of antidysrhythmic drugs. They're classed 1 through 4. And the 5th group, that includes adenosine and digoxin. Membership in the classes of 1 through 4 are determined by the effects of ion movement during slow and fast potentials. So here is an excellent spot to hit pause so you can see the different types of class medications, whether it's class 1 through 4. And I'm pretty sure we'll be discussing each and every single one of these. So let's start off with class 1, your sodium channel blockers. Class 1 drugs block cardiac sodium channels. By doing so, these drugs slow impulses and their conduction in the atria, ventricles, and his Purkinje system. Class 1 constitutes the largest group of antidysrhythmic drugs. Class 2 are our beta blockers. Class 2 consists of beta adrenergic blocking agents. Again, as suggested in figure 41.2, these drugs reduce calcium entry and depress phase 4 depolarization. Beta blockers have 3 prominent effects on the heart. 1. In the SA node, they reduce automaticity. 2. In the AV node, they slow the conduction velocity. And 3. In the atria and the ventricles, they reduce contractility. Cardiac effects of the beta blockers are nearly identical to those of the calcium channel blockers. Class 3, your potassium channel blockers. Class 3 drugs block potassium channels, which was described in Figure 41.2a, and thereby delay repolarization of fast potentials. By delaying the repolarization, these drugs prolong both the action potential duration and the effective refractory period. That brings us to Class 4, our calcium channel blockers. Only two calcium channel blockers, verapamil and diltiazem, are currently employed as antidysrhythmics. Again, as indicated in Figure 41.2, a calcium channel blockade has the same effect on cardiac action potential as would a beta blockade. Accordingly, verapamil and diltiazem, as well as beta blockers, have nearly identical effects on cardiac function, namely reduction of automaticity in the SA node, delay of conduction through the AV node, and reduction of myocardial contractility. Antidysrhythmic benefits derive from suppressing AV nodal conduction. Finally, that brings us to the last section, the other antidysrhythmic drugs, which aren't classified, unfortunately, as class 5, because, that would make sense. This falls into adenosine and digoxin. They do not fit into the four major classes of antidysrhythmic drugs, but both drugs suppress dysrhythmias by decreasing the conduction through the AV node and reducing automaticity in the SA node. So, that brings us to the pro-dysrhythmic effects of antidysrhythmic drugs. Virtually all of the drugs used to treat a dysrhythmia have pro-dysrhythmic effects. That is, all of these drugs can worsen existing dysrhythmias and potentially generate new ones. This ability was documented dramatically in the cardiac arrhythmia suppression trial, in which the use of class 1C drugs to prevent dysrhythmias after a myocardial infarction actually doubled the rate of mortality. Because of their pro-dysrhythmic actions, antidysrhythmic drugs should be used only when dysrhythmias are symptomatically significant, and only when the potential benefits clearly outweigh the risk. Applying this guideline, it would be inappropriate to give antidysrhythmic drugs to a patient with non-sustained ventricular tachycardia, because this dysrhythmia does not significantly reduce cardiac output. Conversely, after a patient is facing death from ventricular fibrillation, any therapy that might work must be tried. In this case, the risk for pro-dysrhythmic effects is clearly outweighing the potential benefits of stopping the fibrillation. Which brings us to the overview of common dysrhythmias and their treatment. The common dysrhythmias can be divided into two major groups, the supraventricular dysrhythmias and the ventricular dysrhythmias. In general, ventricular dysrhythmias are more dangerous than supraventricular dysrhythmias. With either type, intervention is required only if the dysrhythmia interferes with the effective ventricular pumping. Treatment often proceeds in two phases: the termination of the dysrhythmia, followed by the long-term suppression with drugs. Dysrhythmias can also be treated with an implantable cardioverter defibrillator, or ICD, or by destroying small areas of cardiac tissue using radiofrequency catheter ablation. It's important to appreciate that drug therapy of dysrhythmias is highly empiric. In practice, this means that even after a dysrhythmia has been identified, we cannot predict with certainty just which drugs will be effective. Frequently, trials with several drugs are required before control of a rhythm is achieved. In this discussion that follows, only first-choice drugs will be considered. So, let's start off by talking about a supraventricular dysrhythmia. Supraventricular dysrhythmias are dysrhythmias that arise in the area of the heart above the ventricles. So we're speaking strictly of the atria, your SA nodes, and AV nodes. Supraventricular dysrhythmias per se are not especially harmful because dysrhythmic activity within the atria does not significantly reduce cardiac output. Supraventricular dysrhythmias, or tachydysrhythmias, can be dangerous, however, in that atrial impulses are likely to traverse the AV node. resulting in excitation of the ventricles. If the atria drive the ventricles at an excessive rate, diastolic filling will be incomplete and cardiac output will be reduced or declined. Hence, when treating a supraventricular tachydysrhythmia, the objective is frequently the slowing of the ventricular rate, and not the elimination of the dysrhythmia by itself. Of course, if the treatment did abolish the dysrhythmia, this outcome would not be unwelcome. Acute treatment of a supraventricular dysrhythmia is accomplished with vagotonic maneuvers, direct current cardioversion, and certain drugs are class 2 agents and class 4 agents, adenosine and digoxin. Atrial fibrillation. Atrial fibrillation is the most common sustained dysrhythmia, affecting about 2.6 million people in the United States. The disorder is caused by multiple atrial ectopy, foci firing randomly. Each focus stimulates a small area of the atrial muscle. This chaotic excitation produces a highly irregular atrial rhythm, depending on the extent of the impulse transmission through the AV node. Ventricular rate may be very rapid or nearly normal. In addition to compromising cardiac performance, atrial fibrillation carries a high risk for stroke because in patients with atrial fibrillation, some blood can become trapped in the atria, thereby permitting formation of a clot. When normal sinus rhythm is restored, the clot may become dislodged and then may travel to the brain to cause stroke. Treatment of atrial fibrillation has two goals: the improvement of ventricular pumping and the prevention of a stroke. Pumping can be improved by either restoring normal sinus rhythm or slowing the ventricular rate. The preferred method is to slow ventricular rate by long-term therapy with a beta blocker or a cardioselective calcium channel blocker, both of which impede the conduction through the AV node. For a patient who would like to restore normal rhythm, options are DC cardioversion and short-term treatment with drugs, or an RF ablation of the dysrhythmia source. To prevent stroke, patients are treated with warfarin or newer anticoagulants. For those undergoing treatment to restore normal sinus rhythm, warfarin should be taken for 3 weeks before the procedure and 4 weeks after. For those taking an antidysrhythmic drug long-term to control the ventricular rate, warfarin must be taken long-term too. Alternatives to warfarin include 3 new oral anticoagulants: Eliquis, Pradaxa, and Xarelto, and antiplatelet drugs, either aspirin alone or aspirin plus Plavix. Your atrial flutter. Atrial flutter is caused by an ectopic atrial focus, discharging at a rate of 250 to 350 times a minute. Ventricular rate is considerably slower. However, because the AV node is unable to transmit impulses at this high rate, typically one atrial impulse out of the 2 reaches the ventricles. The treatment of choice is a DC cardioversion, which almost always converts atrial flutter to normal sinus. Cardioversion may also be achieved with IV albuterolide. To prevent the dysrhythmia from reoccurring, patients may need long-term therapy with drugs either in class 1C or class 3. There are 2 alternatives to cardioversion: again, an RF ablation of the dysrhythmia focus and a control of the ventricular rate with drugs. As with atrial fibrillation, ventricular rate is controlled with drugs that suppress AV conduction: verapamil, diltiazem, and or a beta blocker. Like atrial fibrillation, atrial flutter poses a risk for strokes, which can be reduced by the treatment with an anticoagulant. Which brings us to our next section, our sustained supraventricular tachycardia, also known as SVT. This is usually caused by an AV nodal reentrant circuit. Heart rate is increased to anywhere between 150 to 250 beats per minute. SVT often responds to interventions that increases vagal tone, such as a carotid sinus massage or a Valsalva maneuver. If these are ineffective, however, an IV beta blocker or calcium channel blocker can be tried. With these drugs, ventricular rate will be slowed even if the dysrhythmia persists. When the dysrhythmia has been controlled, beta blockers and or calcium channel blockers can be taken orally to prevent recurrence. As a last resort, amiodarone can be used for prevention. Ventricular dysrhythmias. In contrast to atrial dysrhythmias, which are generally benign, ventricular dysrhythmias can cause significant disruption of cardiac pumping. Accordingly, the usual objective is to abolish the dysrhythmia. Cardioversion is often the treatment of choice. When antidysrhythmic drugs are indicated, agents in class 1 and or class 3 are usually employed. So, SVT. Ventricular tachycardia arises from a single rapidly firing ventricular ectopic focus, typically located at the border of an old infarction. The focus drives the ventricles at a rate of 150 to 250. Because the ventricles cannot pump effectively at these rates, immediate intervention is required. Cardioversion is the treatment of choice. However, if cardioversion fails to normalize the rhythm, IV amiodarone should be administered. Lidocaine and procainamide are alternatives. For long-term management, drugs such as sotalol or amiodarone or an AICD may be employed. Which brings us to ventricular fibrillation. Ventricular fibrillation is a life-threatening emergency that requires immediate treatment. This dysrhythmia results from the asynchronous discharge of multiple ventricular ectopic foci. Because many different foci are firing, and because each focus initiates contraction in its immediate vicinity, localized twitching takes place all over the ventricles, making coordinated ventricular contraction impossible. As a result, the pumping action of the heart stops. In the absence of blood flow, the patient becomes unconscious and cyanotic. If the heartbeat is not restored rapidly, death will soon follow. Electrical countershock, or a defibrillation, is applied to eliminate fibrillation and restore cardiac function. If necessary, IV lidocaine can be used to enhance the effects of the defibrillation. Procainamide may also be useful. Amiodarone can be used for long-term suppression. As an alternative, an AICD may be employed. The premature ventricular complex, a PVC. PVCs are beats that occur before they should in a cardiac cycle. These beats are caused by ectopic ventricular foci. PVCs may arise from a single ectopic focus or from several foci. In the absence of additional signs of heart disease, PVCs are benign and not usually treated. However, in the presence of an acute myocardial infarction, a PVC may predispose the patient to ventricular fibrillation. In that case, therapy will be required. A beta blocker is the agent of choice in this situation. Are digoxin-induced ventricular dysrhythmias. Digoxin toxicity can mimic practically all types of dysrhythmias. Varying degrees of AV blocks are among the most common. Ventricular flutter and ventricular fibrillation are the most dangerous. Digoxin causes dysrhythmias by increasing automaticity in the atria, ventricles, and his Purkinje system, and by decreasing the conduction of the AV node. With proper treatment, digoxin-induced dysrhythmias can almost always be controlled. Treatment is discussed in Chapter 40. If the antidysrhythmic drugs are required, lidocaine and dilantin are the agents of choice. In patients with digoxin toxicity, a DC cardioversion may bring the ventricular fibrillation, or may bring on a ventricular fibrillation rather. Accordingly, the procedure should be used only when it is absolutely required. Finally, torsades de pointe. Torsades de pointe is an atypical, rapid, undulating ventricular tachycardia that can evolve into a potentially fatal ventricular fibrillation. The main factor associated with the development of the torsades de pointe is the prolongation of the QT interval, which can be caused by a variety of drugs, including the class 1A and class 3 antidysrhythmic agents. Acute management consists of IV magnesium plus a cardioversion for sustained ventricular tachycardia. This brings us to the principles of antidysrhythmic drug therapy. Balancing risks and benefits. Therapy with antidysrhythmic drugs is based on a simple but important concept. Treat only if there is a clear benefit, and then only if the benefit outweighs the risk. As a rule, this means that intervention is needed only when the dysrhythmia interferes with ventricular pumping. Treatment offers two potential benefits: reduction of symptoms and reduction of mortality. Symptoms that can be reduced include palpitations, angina, dyspnea, and faintness. For the most antidysrhythmic drugs, there is little or no evidence of reduced mortality. In fact, mortality may actually increase. Antidysrhythmic therapies carry considerable risk. Because of their pro-dysrhythmic action, antidysrhythmic drugs can exacerbate existing dysrhythmias and potentially generate new ones. Examples of this, for instance, are the toxic doses of digoxin, which can generate a wide variety of dysrhythmias. Drugs that prolong the QT interval can cause torsades de pointe. Many drugs can cause ventricular ectopic beats. Several drugs can cause atrial flutter, and one drug, for instance flecainide, can produce incessant ventricular tachycardias. Because of their pro-dysrhythmic action, antidysrhythmic drugs can increase mortality. Others adverse effects also include heart failure and third-degree AV blocks, as well as many non-cardiac effects, including severe diarrhea, a lupus-like syndrome, and pulmonary toxicity. So, the properties of the dysrhythmia to be considered when it's sustained versus non-sustained dysrhythmias. As a rule, non-sustained dysrhythmias require intervention only when they are symptomatic. In the absence of symptoms, treatment is usually unnecessary. In contrast, sustained dysrhythmias can be dangerous, so the benefit of treatment outweighs the risk. Asymptomatic versus symptomatic dysrhythmias. No study has demonstrated a benefit to treating dysrhythmias that are asymptomatic or minimally symptomatic. In contrast, therapy may be beneficial for dysrhythmias that produce symptoms, including palpitations, angina, dyspnea, and faintness. Supraventricular versus ventricular dysrhythmias. Supraventricular dysrhythmias are generally benign. The primary harm comes from driving the ventricles too rapidly to allow adequate filling. The goal of treatment is either to terminate the dysrhythmia or prevent excessive atrial beats from reaching the ventricles. In contrast to supraventricular dysrhythmias, ventricular dysrhythmias frequently interfere with pumping. Accordingly, the goal of treatment is to terminate the dysrhythmia and prevent its recurrence. Phases of treatment. Treatment has two phases, acute and long-term. The goal of acute treatment is to terminate the dysrhythmia. Many dysrhythmias, the termination is accomplished with discontinuing or with a DC cardioversion or vagotonic maneuvers rather than drugs. The goal of long-term therapy is to prevent dysrhythmias from recurring. Quite often, the risk for long-term therapy or prophylactic therapy outweigh the benefit. Long-term treatment, drug selection, and evaluation. Selecting a drug for long-term therapy is largely empiric. Are there are many drugs that might be employed, and we usually can't predict which one is going to work. Therefore, finding an effective drug is done by trial and error. Drug selection can be aided with an electrophysiologic test. In these tests, a dysrhythmia is generally artificially by programmed electrical stimulation of the heart. If a candidate drug is able to suppress the electrophysiologic induction of dysrhythmia, it may also work against the real thing. So that's when we hand out Holter monitoring devices, which can be used to evaluate treatment. A Holter monitor is a portable EKG device that is worn by the patient around the clock. If Holter monitoring indicates that dysrhythmias are still occurring with the present drug, a different drug should be tried. Minimizing risks. Several measures can help minimize this risk, which include starting with low doses and increasing them gradually, using a Holter monitor during initial therapy to detect danger signs, especially a QT prolongation, which can precede torsades de pointes. And finally, monitoring plasma drug levels. Unfortunately, although drug levels can be good predictors of a non-cardiac toxicity, they are less helpful for predicting adverse cardiac effects. So, looking specifically at the pharmacology of antidysrhythmic drugs. Again, as discussed earlier, the antidysrhythmic drugs fall into four main groups plus that fifth group that includes adenosine and digoxin. Again, here is an excellent spot to hit pause so you can look at this table that shows the properties of antidysrhythmic drugs. So, we'll talk more on the class 1 sodium channel blockers. Class 1 antidysrhythmic drugs block cardiac sodium channels. By doing so, they decrease conduction velocity in the atria, ventricles, and his Purkinje system. There are three subgroups of class 1 agents. Drugs in all three groups block sodium channels. In addition, class 1A agents delay repolarization, whereas class 1B agents accelerate repolarization, and class 1C agents have pronounced prodysrhythmic actions. The class 1 drugs are similar in action and structure to the local anesthetics. In fact, one of these drugs, lidocaine, has both local anesthetic and antidysrhythmic application. Because of their relationship to the local anesthetic, class 1 agents are sometimes referred to as local anesthetic antidysrhythmic agents. So that's what we'll start off with, class 1A, such as quinidine. Quinidine is the oldest, best studied, and most widely used class 1A drug. Accordingly, quinidine will serve as our prototype for all the group. Like other antidysrhythmic agents, quinidine has prodysrhythmic actions. So here again is an excellent spot to hit pause so you can see the prototype drugs that we'll use for each of our antidysrhythmic drugs. We'll talk about each one specifically, but if you want to take a quick peek in advance, here is the spot. So let's talk about the chemistry and source. Quinidine is similar to quinine in structure and action. The natural source of both drugs is the bark of the South American cinchona tree. Accordingly, these agents are referred to as cinchona alkaloids. Like quinine, quinidine has antimalarial and antipyretic properties. Its effects on the heart. By blocking sodium channels, quinidine slows impulse conduction in the atria, ventricles, and his Purkinje system. In addition, the drug delays repolarization at these sites, apparently by blocking potassium channels. Both actions contribute to suppression of dysrhythmias. Quinidine is strongly anticholinergic, atropine-like, and blocks vagal input in the heart. The resultant increase in SA nodal automaticity and AV conduction can drive the ventricles at an excessive rate. To prevent excessive ventricular stimulation, patients are usually pre-treated with digoxin, verapamil, or a beta blocker, all of which would suppress AV conduction. Its effects on the EKG. Quinidine has two pronounced effects on the EKG. The drug widens the QRS complex and prolongs the QT interval. Its therapeutic use, therefore. Quinidine is a broad-spectrum agent, active against supraventricular and ventricular dysrhythmias. The drug principal indication is the long-term suppression of dysrhythmias, including SVT, A-flutter, AFib, and sustained VTAC. To prevent quinidine from increasing ventricular rate, patients are usually pre-treated with an AV nodal blocking agent, again, digoxin, verapamil, or a beta blocker. Quinidine has a black box warning. An analysis of older studies indicate that quinidine may actually increase mortality in patients who have AFib or A-flutter. In addition to the antidysrhythmic application, quinidine is a drug of choice for severe malaria, which we'll discuss more in Chapter 81. Its pharmacokinetics, therefore. Quinidine is rapidly absorbed after oral dosing. Peak response to quinidine sulfate develops in 30 to 90 minutes. Responses to quinidine gluconate develop more slowly, peaking after 3 to 4 hours. Elimination is via the hepatic metabolism. Patients with liver impairment may require a reduction in dosage. Therapeutic plasma levels ought to be 2 to 5 micrograms per ml. Adverse effects: diarrhea and other GI symptoms develop in about one-third of the patient population. These reactions can be immediate and intense, frequently forcing discontinuation of treatment. Gastric upset can be reduced by administering quinidine with food. Synchronism. Synchronism is characterized by tinnitus, headache, nausea, vertigo, and disturbed vision. These can develop with just a single dose. Cardiotoxicity. At high concentrations, quinidine can cause severe cardiotoxicity. These reactions occur secondary to increased automaticity of the Purkinje fibers and reduced conduction throughout all regions of the heart. As cardiotoxicity develops, the EKG changes. Important danger signals are widening of the QRS complex and excessive prolongation of the QT interval. Notify the prescriber immediately if these changes start to occur. Arterial emboli. Embolism is a potential complication of treating AFib. During atrial fibrillation, thrombi may form in the atria. When sinus rhythm is restored, these thrombi may become dislodged and cause an embolism. To reduce the risk for embolism, anticoagulant therapy should be given for 3 to 4 weeks before quinidine and is maintained for an additional 4 weeks. Signs of embolism should be your common sense sudden chest pain, dyspnea, and shortness of breath. Should be reported immediately. Other adverse effects. Quinidine can cause alpha-adrenergic blockade, resulting in a vasodilation and subsequent hypotension. This reaction is much more serious when given with IV therapy rather than oral therapy. Rarely, quinidine can cause hypersensitivity reactions, including fever, anaphylactic reactions, and thrombocytopenia. It does, however, have drug interactions, especially with digoxin. Quinidine can double digoxin levels. The increase is caused by displacing digoxin from plasma albumin and by decreasing digoxin elimination. When these drugs are used concurrently, digoxin dosages must be reduced. Also, patients should be monitored closely for digoxin toxicity. Because of its interaction with digoxin, quinidine is the last choice drug for treating digoxin-induced dysrhythmias. Its other indications. Because of its anticholinergic actions, quinidine can intensify the effects of other atropine-like drugs. One possible result is excessive tachycardia. Phenobarbital, phenytoin, and other drugs that induce hepatic drug metabolism can shorten the half-life of quinidine as much as 50%. Quinidine can intensify these effects of Coumadin by an unknown mechanism. So, preparation, dosage, and administration. Preparations. Quinidine is available as 2-salt quinidine sulfate and quinidine gluconate. Because both these salts have different molecular weights, equal doses do not provide equal amount of quinidine. A 200 mg dose of quinidine sulfate is equivalent to 275 mg of quinidine gluconate. Quinidine sulfate is available in an immediate release tablet and sustained release tablets. Quinidine gluconate is available in sustained release tablets and in a solution for parenteral use. Its dosage. The usual dosage of quinidine sulfate is 200 to 300 milligrams every 6 hours. The usual dosage for quinidine gluconate is 324 to 648 every 8 to 12 hours. Dosage is adjusted to plasma quinidine levels that ought to be between 2 and 5 micrograms per ml. That brings us to procainamide. Procainamide, also known as Procran, is similar to quinidine in action and use. Like quinidine, procainamide is an active against a broad spectrum of dysrhythmias. Unfortunately, serious side effects frequently limit its use. Effects on the heart and EKG. Like quinidine, procainamide blocks cardiac sodium channels, thereby decreasing conduction velocity in the atria, ventricles, and his Purkinje system. Also, the drug delays repolarization. In contrast to quinidine, procainamide is only weakly anticholinergic and therefore is not likely to increase ventricular rate. Effects on the EKG are the same as with quinidine, widening of the QRS complex and prolongation of the QT interval. Its therapeutic use is effective against a broad spectrum of atrial as well as ventricular dysrhythmias. Like quinidine, the drug can be used for long-term suppression. However, prolonged therapy is often associated with serious adverse effects. Procainamide is less desirable than quinidine for long-term use. In contrast to quinidine, procainamide can be used to terminate ventricular tachycardia and ventricular fibrillation. Its pharmacokinetics routes are oral, IV, or intramuscular. Peak plasma levels develop 1 hour after oral dosing. Procainamide has a short half-life and requires more frequent dosing than quinidine. Elimination is via the hepatic metabolism and renal excretion. The major metabolite, the N-acetylprocainamide, or NAPA, has antidysrhythmic properties of its own. NAPA is excreted by the kidneys and can accumulate to toxic levels in patients who have renal impairment. Adverse effects: systemic lupus erythematosus-like syndrome. Prolonged treatment with procainamide is associated with severe immunologic reactions. Within 1 year, about 70% of patients develop anti-nuclear antibodies directed against the patient's own nucleic acid. If procainamide is continued, about 20 to 30% of patients with ANA go on to develop symptoms resembling those of systemic lupus erythematosus, or SLE. These symptoms include pain and inflammation of the joints, pericarditis, fever, and hepatomegaly. When procainamide is withdrawn, symptoms usually slowly subside. If the patient has a life-threatening dysrhythmia for which no alternative drug is available, procainamide can be continued. And the symptoms of SLE should be controlled with a nonsteroidal anti-inflammatory drug such as aspirin or glucocorticoids. All patients seeking procainamide chronically should be tested for ANA. If the ANA titer rises, discontinued treatment should be considered. So there is our black box warning on blood dyscrasias. So about 0.5% of patients develop blood dyscrasias, including neutropenia, thrombocytopenia, and agranulocytosis. Fatalities have occurred. These reactions develop during the first 12 weeks of treatment. Complete blood count should be obtained weekly during this time and periodically thereafter. After a complete blood count should be obtained promptly at the first sign of an infection, bruising, and bleeding. If blood counts indicate bone marrow suppression, procainamide should be withdrawn. Hematologic status usually returns to baseline within 1 month. Cardiotoxicity. Procainamide has cardiotoxic actions similar to those of quinidine. Warning signs are QRS widening and excessive QT prolongation. If these develop, the drug should be withdrawn and the prescriber should be informed. Other adverse effects. Again, similar to quinidine, procainamide or procainamide can cause GI symptoms and hypotension. However, these are much less prominent than with quinidine. Procainamide is a derivative of procaine, therefore its use is contraindicated in patients who have a history of procaine allergy. As with quinidine, atrial embolism may occur during treatment of atrial fibrillation. Preparation, dosage, and administration. Procainamide is available orally in Canada only. There are several different capsules with different doses. I'm going to have you stop and hit pause, and you can read over these yourself, only because there's too many different ones that we'll be going through today. Um, Most of the capsules, though, are administered every 3 to 4 hours, and the sustained release tablets every 6. Again, there is a drug plasma level that ought to be between 3 and 10 micrograms per ml. If there are any specific levels that we need to know, I will mention them and I will keep reading them aloud. But if there's just dosages, go ahead and take a look, please. Your disopyramide. Disopyramide, also known as Norpace, is a class 1 drug with actions like those of quinidine. However, because of its prominent side effects, indication for disopyramide are limited. Effects on the heart and EKG. Cardiac effects are similar to those of quinidine. By blocking sodium channels, this disopyramide decreases conduction velocity in the atria, ventricles, and the His-Purkinje system. In addition to drugs delay repolarization, anticholinergic actions are greater than those of quinidine. In contrast to quinidine, however, disopyramide causes a pronounced reduction in contractility. Like quinidine, disopyramide widens QRS complexes and prolongs the QT interval. So our adverse effects. Anticholinergic responses are the most common. These include dry mouth, blurred vision, constipation, and urinary hesitancy or retention. Urinary retention frequently requires a discontinuation of treatment. Because of its negative inotropic effects, disopyramide can cause severe hypotension and can exacerbate heart failure. The drug should not be administered to a patient who has a history of heart failure or to patients who are taking a beta blocker. Whenever disopyramide is used, pressor drugs should be immediately available. Its therapeutic use. Disopyramide is indicated only for ventricular dysrhythmias. The drug is reserved for patients who cannot tolerate safer medications. So it has its own black box warning. Disopyramide. There are increased risk for mortality when using this medication to treat non-life-threatening arrhythmias. Its preparation, dosage, and administration is available in an immediate and extended release capsule. Its initial loading dose needs to be 200 to 300 milligrams, and its maintenance dose every 100 to 200 milligrams every 6 hours. That was all of our Class 1A agents. Now let's talk about Class 1B agents. As a group, Class 1B differs from quinidine and other Class 1A agents in two respects. Whereas Class 1A agents delay repolarizations, Class 1B agents accelerate repolarization. Also, Class 1B agents have little or no effect on EKGs. So, the first, mexiletine, is an oral analog of lidocaine used for symptomatic ventricular dysrhythmias. Principal indication are PVCs and sustained ventricular tachycardia. Similar to lidocaine, mexiletine does not alter the EKG. The drug is eliminated via the hepatic metabolism, so effects may be prolonged in patients with liver disease or be reduced by the hepatic blood flow. The most common adverse effects are GI upset and neurologic disturbances. About 40% of patients find these intolerable. Like other class 1 agents, mexiletine has pro-dysrhythmic properties. The dosage should be 200 milligrams every 8 hours. All doses should be taken with food. Milexitine has a black box warning because it has been associated with an increased risk for mortality when used to treat, again, non-life-threatening arrhythmias. Which brings us now to Class 1C agents. Class 1C antidysrhythmics block cardiac sodium channels and thereby reduce the conduction velocity in the atria, ventricles, and His-Purkinje system. In addition, these drugs delay ventricular repolarization, causing a small increase in the effective refractory period. All Class 1C agents can exacerbate existing dysrhythmias and create new ones. Currently, only two Class 1C agents are available, flecainide and propafenone. Flecainide, also known as Tabacor, is active against a variety of ventricular and supraventricular dysrhythmias. However, use is restricted largely to the maintenance therapy of supraventricular dysrhythmias. Like other class 1C agents, flecainide decreases cardiac conduction and increases the effective refractory period. Prominent effects on the EKG are the prolongation of the PR interval and the widening of the QRS complex. Excessive QRS widening indicates a need for dosage reduction. Flecainide has a pro-dysrhythmic effect. As a result, the drug can intensify dysrhythmias and provoke new ones. In patients with asymptomatic ventricular tachycardia associated with the acute myocardial infarction, flecainide has caused a twofold increase in mortality. Flecainide decreases myocardial contractility and can thereby exacerbate or precipitate heart failure. Accordingly, the drug should not be combined with other agents that can decrease contractile force. Elimination is by hepatic metabolism and renal excretion. Flecainide is available in tablets for oral dosing. Dosage is low initially and then gradually increases to a maximum of 400 milligrams per day. So, flecainide has a black box warning. Because its potential for serious side effects, flecainide should be reserved for severe ventricular dysrhythmias that have not responded to safer drugs. Patients should be monitored closely. This brings us to propafenone, also known as Rhythmol. It is similar to flecainide in action and use. By blocking cardiac sodium channels, the drug decreases conduction velocity in the atria, ventricles, and his Purkinje system. In addition, it causes a small increase in the ventricular ERP. Prominent effects on the EKG are QRS widening and PR prolongation. Similar to flecainide, Rhythmol has pro-dysrhythmic action that can exacerbate existing dysrhythmias and create new ones. It is not known whether Rhythmol, like flecainide, increases mortality in patients with asymptomatic ventricular dysrhythmias after myocardial infarction. Rhythmol has beta-adrenergic blocking properties and can therefore decrease myocardial contractility and promote a bronchospasm. Accordingly, the drug should be used with caution in patients who have heart failure, an AV block, or asthma. Non-cardiac adverse effects are generally mild and include dizziness, an altered taste, blurred vision, and some GI symptoms. Rhythmol is available in immediate-release tablets and extended-release capsules. For the immediate-release tablets, the dosage should be 150 milligrams every 8 hours and can be gradually increased to 300 milligrams every 8 hours. For the extended-release capsules, the dosage is 225 every 12 hours and can be gradually increased to 425 every 12 hours. So, our Rhythmol has a black box warning. Because of its pro-dysrhythmic action, Rhythmol should be reserved for patients who have not responded again to safer drugs. So those were all of our class 1 medications. Now we'll jump on to class 2, which are our beta blockers. Class 2 consists of our beta-adrenergic blocking agents. At this time, 4 beta blockers, propranolol, acebutolol, esmolol, and sotalol, are approved for treating dysrhythmias. One of these drugs, sotalol, also blocks potassium channels and is discussed under Class 3. The basic pharmacology of the beta blockers is presented in Chapter 14. Discussion here is strictly limited to their antidysrhythmic use. So, propranolol, also known as Inderal, is considered a non-selective beta-adrenergic antagonist in that it blocks both beta-1 and beta-2 adrenergic receptors. Beta-1 blockade affects the heart, and beta-2 blockade affects the bronchi. So its effects on the heart and EKG. Blockade of cardiac beta-1 receptors attenuates sympathetic stimulation of the heart. The result is a decreased automaticity of the SA node, decreased velocity of conduction through the AV node, and a decreased myocardial contractility. The reduction in AV conduction velocity translates to a prolonged PR interval on the EKG. It is worth noting that cardiac beta 1 receptors are functionally coupled to calcium channels, and that beta 1 blockade causes these channels to close. Therefore, the effects of a beta blocker on the heart rate, AV conduction, and contractility all result from a decreased calcium influx. Because beta blockers and calcium channel blockers both decrease calcium entry, the cardiac effects of these drugs are very similar. Its therapeutic use. Propranolol is especially useful for treating dysrhythmias caused by excessive sympathetic stimulation of the heart. Among these are sinus tachycardia, severe recurrent ventricular tachycardias, exercise-induced tachydysrhythmias, and paroxysmal atrial tachycardias, evoked by emotion or exercise. In patients with supraventricular tachydysrhythmias, propranolol has two beneficial effects: suppression of excessive discharge of the SA node, and the slowing of ventricular rate by decreasing the transmission of atrial impulses through the AV node. Adverse effects. Beta blockers are generally well tolerated. Principal adverse effects concern the heart and bronchi. By blocking cardiac beta 1 receptors, propranolol can cause heart failure, AV block, and sinus arrest. Hypotension can occur secondary to the reduced cardiac output. In patients with asthma, blocking beta 2 receptors in the lung can cause bronchospasms. Because of its cardiac and pulmonary effect, propranolol should be used cautiously in patients with asthma and is contraindicated in patients with sinus bradycardia, high degree heart block, and heart failure. So, our dosage and administration. Propranolol is administered orally and in life-threatening emergencies via IV injection. Dosage requires either route to show a wide individual variation. Oral dosage ranges from 10 to 30 milligrams every 6 to 8 hours. The usual IV dose is 1 to 3 milligrams injected at a rate of 1 milligram per minute. Acebutolol, also known as Sectrol, is a cardioselective beta blocker approved for oral therapy of PVCs. Adverse effects are like those of propranolol: bradycardia, heart failure, AV block, and, despite cardioselectivity, bronchospasms. Accordingly, acebutolol should be used cautiously in patients with asthma and is contraindicated again with patients with heart failure, severe bradycardia, and AV blocks. Acebutolol can cause adverse immunologic reactions. Titers of ANAs may rise, resulting in myalgia, arthralgia, and arthritis. For the suppression of PVCs, the initial dose is 200 milligrams twice daily. The usual maintenance dose is anywhere between 600 to 1200 milligrams per day. That was our Class 2s. Now we're speaking on Class 3 drugs, our potassium channel blockers. 5 Class 3 antidysrhythmics are available: amiodarone, dronedarone, dofetilide, abutolide, and sotalol, which is also a beta blocker. All 5 delay the repolarization of fast potentials, hence all 5 prolong the action potential duration and ERP. By doing so, they prolong the QT interval. In addition, each drug can affect the heart in other ways, and so they are not interchangeable. 4 of the drugs are discussed below. Abutolide is available IV only and is therefore discussed in Chapter 89. So we'll speak on the one that is most commonly used still today: amiodarone. Amiodarone, also known as quarterone or pacerone, is a Class 3 antidysrhythmic agent that has complex effects on the heart. The drug is highly effective against both atrial and ventricular dysrhythmias. Unfortunately, serious toxicities are common and may persist for months after treatment has already stopped. Because of toxicity, amiodarone is approved only for life-threatening ventricular dysrhythmias that have been refractory to safer agents. Nonetheless, because of its efficacy, amiodarone is one of the most frequently prescribed antidysrhythmic drugs, used for atrial and ventricular dysrhythmias alike. Amiodarone is also available for oral and IV use. Indication, electrophysiologic effects, time of course, and adverse effects differ for each route. Accordingly, oral and IV therapy will be discussed separately. So, its oral therapeutic use. Amiodarone is very effective. Concerns about toxicity limiting its indication. In the US, oral amiodarone is approved only for long-term therapy of two life-threatening ventricular dysrhythmias, recurrent ventricular fibrillation and recurrent hemodynamically unstable ventricular tachycardia. Treatment should be reserved for patients who have not responded to safer drugs. Amiodarone is our most effective drug for AFib and is prescribed widely to treat this dysrhythmia, even though it is not approved for this use. The drug is given to convert atrial fibrillation to normal sinus rhythm and to maintain a sinus rhythm after a conversion. The effects on the heart and EKG. Amiodarone has complex effects on the heart. Like all other drugs in this class, amiodarone delays repolarization and therefore prolongs the action potential duration of and ERP. The underlying cause and these effects may be blockade of potassium channels. Additional cardiac effects include reduced automaticity in the SA node, reduced contractility, and reduced conduction velocity in the AV node, ventricles, and his Purkinje system. These occur secondary to blockade of sodium channels, calcium channels, and beta receptors. Prominent effects on the EKG and QRS widening and prolongation of the PR and QT interval. Amiodarone also acts on coronary and peripheral blood vessels to promote dilation. Its pharmacokinetics. Amiodarone is highly lipid soluble and accumulates in many tissues, especially in the liver and the lungs. The drug is metabolized in the liver by CYP3A4 and then excreted in the bile. Amiodarone has an extremely long half-life, ranging from 25 to 110 days. Because of this slow elimination, amiodarone continues to act long after dosing has ceased. Adverse effects. Amiodarone produces many serious adverse effects. Furthermore, because the drug's half-life is protracted, toxicity can continue for weeks or months after the drug already has been withdrawn. To reduce adverse effects, the FDA requires that all patients using amiodarone be given a medication guide prescribing potential toxicities. The black box warning on pulmonary toxicity. Lung damage, hypersensitivity, pneumonitis, and interstitial alveolar pneumonitis. Pulmonary fibrosis is the greatest concern. Symptoms resemble that of heart failure and pneumonia. Pulmonary toxicity develops in 2 to 17% of patients and carries a risk of 10% for mortality. Patients at highest risk are those receiving long-term high-dose therapy. A baseline chest radiograph and pulmonary function test are recommended. Pulmonary function should also be monitored throughout treatment. If lung injury develops, amiodarone should be withdrawn. So, cardiotoxicity. Amiodarone may cause a paradoxical increase in dysrhythmic activity. In addition, by suppressing the SA and AV node, the drug can cause sinus bradycardia and AV block. By reducing contractility, amiodarone can precipitate heart failure. Thyroid toxicity. Amiodarone may cause hypothyroidism or hyperthyroidism. Accordingly, a thyroid function should be assessed at baseline and periodically during treatment. Hypothyroidism can be treated with a thyroid hormone supplement, whereas hyperthyroidism can be treated with an antithyroid drug or a thyroidectomy. Discontinuing amiodarone ought to be considered at that point. So, its black box warning, because why wouldn't it have one, is liver toxicity. Amiodarone can injure the liver. Accordingly, tests of liver function should be obtained at baseline and periodically throughout. If circulating liver enzymes exceed 3 times the normal level, amiodarone needs to be discontinued. Again, our signs and symptoms of liver injury, which are seen only rarely, can include anorexia, nausea, vomiting, malaise, fatigue, itching, jaundice, and dark urine. Ophthalmic effects. Rarely, amiodarone has been associated with optic neuropathy and optic neuritis, sometimes progressing to blindness. However, a causal relationship hasn't been established. Patients who develop changes in visual acuity or peripheral vision should undergo ophthalmologic evaluation. If optic neuropathy or neuritis is diagnosed, discontinuation of amiodarone should be considered. Virtually all patients develop a corneal microdeposit. Fortunately, these deposits have little or no effect on vision itself, and so rarely necessitate amiodarone's cessation. Toxicity in pregnancy and breastfeeding. Amiodarone crosses the placental barrier and enters breast milk, and can thereby harm the developing fetus and breastfeeding infant. Accordingly, pregnancy and breastfeeding should be avoided while using the drug and for several months after stopping. Dermatologic toxicity. Patients frequently experience photosensitivity reactions. To reduce this risk, patients should avoid sun lamps and should wear sunblock and protective clothing when outdoors. With frequent and prolonged sun exposure, exposed skin may turn bluish gray. Fortunately, this discoloration resolves within months after amiodarone has been discontinued. Other adverse effects. Possible CNS reactions include ataxia, dizziness, tremor, mood alterations, and hallucinations. GI reactions are also common. Amiodarone can increase levels of several drugs, including quinidine, procainamide, dilantin, digoxin, diltiazem, warfarin, cyclosporins, and 3 statins, lovastatin, simvastatin, and atorvastatin. Dosage of these agents often require a reduction. I say this because amiodarone is subject to significant interactions with many drugs. As a result, can be toxicity or reduced therapeutic effect. Amiodarone levels can be increased by grapefruit juice or by inhibiting the CYP3A4. Toxicity can result. Amiodarone levels can be reduced by cholecystiramine foods and by agents that again induce that CYP3A4. The risk for the severe dysrhythmias is increased when they are using a diuretic and by drugs that prolong the QT interval, of which again there are so many. Combining amiodarone with a beta blocker, verapamil, and or diltiazem can lead to excessive slowing of the heart rate. So our dosage, again, we're speaking strictly just on the oral aspect. There are available tablets in 100, 200, and 400 milligrams. Treatment should be initiated in a hospital, and there should be a follow-up schedule, especially if there is a need for a loading dose. And so that brings us to dronedarone. Dronedarone, or Multac, is a derivative of amiodarone. The drug is indicated for oral therapy of aflutter and paroxysmal or persistent AFib, but not permanent AFib. The manufacturer hoped to create a drug with the high efficacy of amiodarone, but with less toxicity. Unfortunately, although dronedarone is somewhat less toxic than amiodarone, it is also less effective. Furthermore, in patients with heart failure or a permanent AFib, dronedarone doubles the risk for death. Dronedarone has a much shorter half-life than amiodarone, so adverse effects resolve usually more quickly. Its effects on the heart and EKG. Like other class 3 agents, dronedarone blocks cardiac potassium channels and thereby delays repolarization. In addition, dronedarone blocks sodium channels, beta-adrenergic receptors, and calcium channels. Just how these actions contribute to the antidysrhythmic benefits are still unclear. Prominent effects on the EKG are PR and QT prolongation and the widening of the QRS complex. So, its pharmacokinetics. Oral bioavailability is low in the absence of food and higher in the presence of food. Plasma levels peak in 3 to 6 hours after dosing. Dronedarone undergoes extensive metabolism by hepatic CYP3A4, followed by the excretion in the feces. The elimination half-life is 13 to 19 hours, much shorter than the 25 to 110 days seen with amiodarone. As a result, the steady-state levels are achieved fairly quickly with dronedarone, which is 4 to 8 days, compared to the 1 to 5 months. Adverse effects. The most common side effects are diarrhea, weakness, nausea, and skin reactions. Dronedarone does not cause significant thyroid toxicity, pulmonary toxicity, or other toxicity, although it can cause liver toxicity. It can increase skin sensitivity to sunlight, but it does not cause any kind of bluish-gray skin discoloration that we would see with amiodarone. Furthermore, it has a much shorter half-life than amiodarone, so any adverse effects that do occur have a much shorter duration. It does, however, have its cardiac effects, so there is a black box warning. In patients with severe heart failure, dronedarone doubles the risk for death, as shown the Andromeda trial. Accordingly, the medication is contraindicated with patients with New York Heart Association Class 4 heart failure and in patients with a Class 2 or Class 3 heart failure with recent decompensation that requires hospitalization. So, in patients with a permanent atrial fibrillation, again, dronedarone doubles the risk for death, as shown in a Palace trial. Accordingly, dronedarone should not be used in any of these patients. Again, dronedarone reduces that SA nodal automaticity and AV nodal conduction, posing a risk for bradycardia and a heart block. Accordingly, the drug is contraindicated in patients who also have sick sinus syndrome or have a second or third degree AV block, unless there is already a pacemaker present, and in patients with bradycardia with a heart rate that is less than 50 beats per minute. Dronedarone, again, prolongs that QT interval by about 10 microseconds. Accordingly, the drug should not be used in patients with a QT interval greater than 500 mSec or a patient taking drugs or supplements that cause a QT prolongation. Liver toxicity. The medicine has been associated with a rare case of severe liver injury, including 2 heart-required liver transplants. Accordingly, patients should be warned about the signs and symptoms of liver injury and be instructed to contact their provider immediately if these symptoms start to develop. Providers also should consider monitoring for liver enzymes in blood, especially during the first 6 months of treatment. Its toxicity in pregnancy and breastfeeding. Again, dronedarone is a proven teratogen and must not be given during pregnancy. In animal studies, doses at or even below the mean recommended human dose have produced visceral, skeletal, and external malformations. Therefore, the FDA has declared that this is a risk category X, and risk to the developing fetus clearly outweighs any possible benefit. Any woman of childbearing age should be counseled about using effective contraception. We know that the medication is also excreted in the milk of rats, but information in lactating women is currently still lacking. Nonetheless, you probably shouldn't take the medication if you're nursing to decrease the risk to a breastfeeding infant. Drug interactions. Dronedarone is subject to multiple drug interactions due to its CYP3A4. So, strong inhibitors of the CYP3A4 can make the medication accumulate to dangerous levels. Accordingly, concurrent use of the inhibitors is also contraindicated. Again, if we're thinking of that grapefruit juice, moderate inhibitors of hepatic CYP3A4 should be used with caution, and strong inducers can reduce dronodon's level by as much as 80% and can therefore greatly reduce dysrhythmia control. In addition to being a substrate to CYP3A4, the medication can inhibit the enzyme. Accordingly, it can raise the levels of other drugs that are CYP3A4 substrates. Substrates have a narrow therapeutic range and should be used with caution. Again, because the medicine can also inhibit CYP2D6, it can therefore increase levels of CYP2D6 substrates, and concurrent use of these agents should be done with caution. Beta blockers, which suppress the SA node in AV conduction, can intensify Dronderons-induced bradycardia and can therefore increase the risk for a further AV block. Like the beta blockers, two calcium channel blockers, verapamil and diltiazem, also can suppress the SA and AV conduction, and therefore pose the same risk as the beta blockers. In addition, verapamil and diltiazem can inhibit CYP3A4 and can therefore raise Dronderons levels, making the risk for cardiosuppression even greater. Drugs and supplements that prolong the QT interval can intensify Dronderons-induced QT prolongation and can therefore increase the risk for torsades de pointes. Accordingly, these drugs are contraindicated for the use with Dronderon. So, contraindications. According to the NYHA, any class 4 heart failure or NYHA class 2 or 3 heart failure with recent decompensation that has required hospitalization. Patients with liver or lung toxicity related to previous amio use should not use this medicine. Again, it's not for the treatment of permanent AFib, so not indicated. Patients with a second or third degree AV block or sick sinus syndrome should not use this medicine unless they have a pacemaker, which then overrides that. Bradycardia with a heart rate less than 50. A PR greater than 280 ms, a QT greater than 500 ms, the use of drugs or supplements that would prolong QT intervals, the use of strong inhibitors of CYP3A4. Again, if you're pregnant, breastfeeding, or have severe liver impairments, do not use this medication. So, its preparation, dosage, and administration. Again, the medicine Dronedarone is supplied in 400 milligrams tablets for oral dosing, and the recommended dose is 400 milligrams twice daily, taken once in the morning and evening with their meals. Which brings us to sotalol. Sotalol, also known as beta-pace, is a beta blocker that also delays the repolarization. Therefore, the drug has combined class 2 and class 3 antidysrhythmic properties. Pro-dysrhythmic properties are pronounced. Sotalol was initially approved only for ventricular dysrhythmias, such as sustained VTAC, that are considered life-threatening. Later, it was approved for the prophylaxis and the treatment of A-flutter and AFib, but only if symptoms are severe. The drug is not approved for hypertension or angina. Its pharmacokinetics. Sotalol is administered orally and undergoes nearly complete absorption. The drug is excreted unchanged in urine and has a half-life of 12 hours. It does come with a nice big black box warning. Sotalol can cause torsades de pointes, a serious dysrhythmia that develops in about 5% of patients. So that's 1 in 20. Risk an increase by hypokalemia and by other drugs that prolong the QT interval. At therapeutic doses, sotalol produces substantial beta blockade. It can cause bradycardia, AV block, heart failure, and bronchospasms. Accordingly, the usual contraindication to beta blockers therefore apply. Preparation, dosage, and administration. Sotalol is available under two trade names, again, Betapase and Betapase AF. Betapase is intended for treating ventricular dysrhythmias. Betapase AF is intended for treating atrial fibrillation or atrial flutter. Although tablets are the same under both trade names, packaging differs. Packaging for Betapase provides information specific for treating ventricular dysrhythmias, whereas the packaging for Betapase AF provides information specific for treating atrial dysrhythmias. The two should not be interchanged. For both types of dysrhythmias, treatment should start in a hospital. Dosing for both is the same. The initial dosage is 160 milligrams per day, and the maintenance dose is 160 to 320 in 2 or 3 divided doses. The dosing interval should be increased in patients who have renal impairment. So that brings us to dofetilide, also known as Ticasin. Ticasin is an oral class 3 antidysrhythmic indicated for restoring and maintaining normal sinus in patients with a flutter or AFib. The drug causes dose-related QT prolongation and therefore poses a serious risk for Torsades de Pointes. Accordingly, it should be reserved for patients with high symptomatic atrial dysrhythmias. Initial treatment requires continuous EKG monitoring in the hospital. Dosage must be carefully titrated on the basis of renal function tests. Ticasin is available only through authorized hospitals and prescribers. So, for those who have never given Ticasin before, you need to give a EKG about 1 hour after dosing the patient with their Ticasin to assess for QT prolongation. So, reading here, effects on heart and EKG. Like other class 3 agents, Ticasin blocks cardiac potassium channels and delays repolarization, a prolonging of the QT interval. Ticasin does not affect the PR interval or widen the QRS and has no effect on cardiac beta receptors or sodium channels. However, your pharmacist will care about that QT interval or their QTC. Ticasin is well absorbed, 90% both in the presence and absence of food. Very little, however, is metabolized. 80% of each dose is excreted in the urine, primarily even unchanged. Renal excretion, again, results largely from the active tubular secretion mediated by cationic pumps. In patients with normal renal function, the drug's half-life is about 10 hours. However, in patients with renal impairment, the half-life is increased. In patients with moderate renal impairment, dosage must be reduced. In patients with severe renal impairment, Ticasin must not be used. So it's black box warning. By increasing the QT interval, Ticasin predisposes to Torsades de Pointes, which can progress to a fatal ventricular fibrillation. The risk is directly related to Ticasin's blood levels and is increased by hypokalemia and by other drugs that cause a QT prolongation. To assess the risk, an EKG should be obtained at baseline, and EKG monitoring should be continuous during initial treatment. Ticasin is contraindicated for patients with a baseline QT interval greater than 440 mseconds. So, drug interaction. Ticasin, or drugs that are excreted by renal cation pumps, can interfere with the excretion of Ticasin, therefore causing its levels to rise. Accordingly, concurrent use of these drugs is contraindicated. Drugs that prolong a QT interval may increase the risk for dysrhythmias, and so should also be avoided. Among these are the class 1 and class 3 antidysrhythmics, your phenothiazines, tricyclic antidepressants, and some macrolide antibiotics. Combining verapamil with Ticasin increases the risk for Torsades de Pointes and should therefore be avoided. Preparation. Dosage and administration. Ticacin is available in capsules for oral dosing. Because of the risk for dysrhythmias, treatment must be initiated in a hospital with continuous EKG monitoring for at least 3 days. Again, because dysrhythmia risk is related to plasma drug level, which in turn are directly related to the creatinine clearance must be monitored. Dosage should be reduced with decreasing creatinine clearance, as follows with patients with normal renal function. Giving 500 micrograms twice a day for creatinine clearance of 40 to 60 ml per minute. And actually, I'm going to say hit pause here so you can read this and write these numbers down. They are important to note, and I'm sure we will see these coming again. Again, if a QT interval becomes excessively prolonged, greater than 500 mSecs or greater than 500 mSecs in patients with ventricular conduction abnormalities, the dosage must be reduced. Which brings us finally to our class 4 calcium channel blockers. There are only 2 calcium channel blockers, verapamil and diltiazem, which are able to block calcium channels in the heart. Accordingly, they are the only calcium channel blockers which can be used to treat dysrhythmias. Their basic pharmacology was discussed in chapter 37. Considerations here are limited to their use against dysrhythmias. So, the effects on the heart and EKG. The blockade of cardiac calcium channels has 3 effects: slowing of SA nodal automaticity, delay of AV nodal conduction, and the reduction of myocardial contractility. Note that these are identical to the effects of a beta blocker, which makes sense in that beta blockers promote calcium channel closure in the heart. The principal effect on the EKG prolongation of the PR interval, reflecting delayed AV conduction. Its therapeutic use. Verapamil and diltiazem have 2 antidysrhythmic uses. First, they can slow ventricular rate in patients with AFib or aflutter. Second, they can terminate SVT caused by AV nodal reentrant circuit. In both cases, the benefits derive from suppressing AV nodal conduction with IV administration. Effects can be seen in 2 to 3 minutes. Verapamil and diltiazem are not active against ventricular dysrhythmias. Adverse effects. Although generally safe, these drugs can cause undesired effects. Blockade of cardiac calcium channels can cause bradycardia, AV block, and heart failure. The blockade of calcium channels in vascular smooth muscle can cause the vasodilation, resulting in hypotension and peripheral edema. Blockade of calcium channels in intestinal smooth muscle can produce constipation. Drug interactions. Both verapamil and diltiazem can elevate levels of digoxin, therefore increasing the risk of digoxin toxicity. Also, because digoxin shares with verapamil and diltiazem the ability to decrease AV conduction, combining digoxin with either drug increases the risk of an AV block. Because verapamil, diltiazem, and beta blockers have nearly identical suppressant effects on the heart, combining verapamil or diltiazem with a beta blocker increases the risk for bradycardia, AV block, and heart failure. So, preparation, dosage, and administration. For verapamil, dosing may be IV or oral. IV therapy is preferred for initial treatment. Oral therapy is used for maintenance. Verapamil for oral use is available in immediate and sustained release tablets. The maintenance dosage is 40 to 120 milligrams 3 to 4 times a day. For diltiazem, similar to verapamil, diltiazem may be given by IV or PO routes. IV therapy is preferred for initial treatment, and oral therapy is used, therefore, for maintenance therapy. Diltiazem for oral use is available in immediate release and extended release tablets. Again, the dosing is anywhere from 120 to 360 milligrams taken daily in about 4 divided doses. Other antidysrhythmic drugs are digoxin. Although its primary indication is heart failure, digoxin or lanoxin is also used to treat supraventricular dysrhythmias. Its pharmacology is discussed in Chapter 40. Consideration here is limited to the treatment of dysrhythmias. Its effects on the heart, therefore. Digoxin suppresses dysrhythmias by decreasing conduction through the AV node and by decreasing automaticity in the SA node. The drug decreases AV conduction by a direct depressant effect on the AV node and by acting on the CNS to increase vagal impulses to the AV node. Digoxin decreases automaticity of the SA node by increasing vagal traffic to the node and by decreasing sympathetic traffic. It should be noted that although digoxin decreases automaticity in the SA node, it can increase the automaticity in the Purkinje fibers. The latter effect contributes to the dysrhythmias caused by digoxin. Effects on EKG. By slowing AV conduction, digoxin prolongs the PR interval. The QT interval may be shortened, reflected accelerated repolarization of the ventricles. Depressing of the ST segment is common. The T wave may be depressed or even inverted. There is little or no change in the QRS complex. Its adverse effects and interactions. The major adverse effects is cardiotoxicity. Risk is increased by hypokalemia, which can result from concurrent therapy with diuretics. Accordingly, it is essential that potassium levels be kept within the normal range. The most common adverse effects are GI disturbances. CNS responses are also relatively common. Its antidysrhythmic use. Digoxin is used only for the supraventricular dysrhythmia. The drug is inactive against ventricular dysrhythmias. So, an AFib and a flutter. Digoxin can be used to slow the ventricular rate in patients who have AFib or a flutter. Ventricular rate is reduced by reducing the number of atrial impulses that pass through the AV node. In supraventricular tachycardia, digoxin may be employed acutely or chronically to treat SVT. Acute therapeutic is used to abolish the dysrhythmia. Chronic therapy is used to prevent the return. Digoxin suppresses SVT by increasing cardiac vagal tone and by decreasing the sympathetic tone. Finally, its dosage and administration. Oral therapy is preferred with an initial dose of 1 to 1.5 milligrams administered 3 or 4 times over 24 hours. Maintenance dosage is 0.25 to 0.5 milligrams per day. This dose should be decreased in patients who have renal impairment. And that concludes our chapter here for today. I thank you for listening as always, and I hope you have a good day.